head should lie medial to the lateral humeral line. So in bad or type 3, the lateral humeral line may become medial to the radial epiphysis, or it may just touch the radial epiphysis. So whenever you find this, then you have to think there is a lateral dislocation of the radiocapsular joint. So why these lines came into work? It's because radiocapsular line, there are a lot of confusion whether you have to draw the line in the mid diaphysis of the radius or along the radial neck, or sometimes there are papers which show it's better to mark the midpoint of the radial epiphysis and the midpoint of the distal radial epiphysis. So and you connect them, that is even better. So because of all these confusions, and in 15% it is not reliable, we are using the lateral humeral line also. Now coming to the management part, how to manage this child? Is a simple close reduction enough, or we have to do some fixation also? So most of us have learned the close reduction and conservative management of upper limb fractures from Professor K. Wilkins. So I am going to use some of his illustrations in this talk too. So how to treat a Monteggia is by reversing the injury mechanism. As we have discussed, this Monteggia is an extension lesion. So whenever the child falls with outstretched hand, there is an extension moment. So to reduce that, you have to give a flexion moment. So always you try to correct the ulnar angulation first. So you have to give a 3-point pressure, and for sustained duration of time, if you give this pressure, the ulnar angulation will get reduced and it will maintain the length and the alignment. Once you do that, the radial head will automatically fall back in position. But sometimes you may need to give a direct thrust on the radial head also to reduce it. Most of the times there won't be any issue. But suppose if you feel there is a soft end, or if you feel the radial head is not reducing properly, then immediately you have to go and do an orthogram. So orthogram will give you the congruency of the radiocapsular reduction. If it is not there, it means there is some entrapment. There might be a buttonholing of the annular ligament, or it may go and get entrapped in the radiocapsular joint. And very rarely there have been case reports where even the posterior interosseous nerve has been entrapped in the radiocapsular joint. So this patient, we did the close reduction. As you can see, the entire ulna has become straight and the radial head has fallen back in place. So it was stable in varying ranges of motion. Now how to proceed? Will you fix it or will you put a cast? If so, how to do? So as per Professor K. Wilkins, most of these fractures will remain stable in a hyperflexion cast. So you have to use a figure of 8 technique, leaving the antecubital fossa free to prevent compression and compartment syndrome. But whenever there is a complete fracture, this casting is not enough. So you have to go for a stabilization using an intramedullary fixation, either an elastic stable intramedullary nail or a simple K wire. If there is a length unstable fracture, then you have to plate it. And as I described, whenever you think the radial head is irreducible or it is subluxing, then go for open traction of the radial head. So this is one another case where there is a complete fracture of the ulna with anterior dislocation, a type 1. So here we did a close reduction and we used a intramedullary K wire. So the advantages of putting a K wire is like we can leave it outside, so that the removal part we can do in the OP setup. But if you there is a little bit risk of pintract infection, you have to be careful. Otherwise you can bury an elastic stable intramedullary nail. Coming to the type 2 fracture, this is a very rare type. As you can see, there is a posterior angulation. So in the proximal ulna, there is a posterior angulation and there is a posterior dislocation of the radial head. So how this happens? It is not because of a fall on outstretched hand. Here the child falls with a bent elbow. Most of the times that will result in a posterior dislocation of the elbow, but if the proximal ulnar metaphysis is weak enough, then it might result in a type 2 BADO. So being a flexion type of injury, to reduce this, we have to do an extension maneuver. So reversing the mechanism. And sometimes you may have to put an intramedullary fixation or immobilize it in extension cast. Otherwise it might spring back in the check x-rays. Always take check x-rays for this every once in a week, for 3 weeks at least you have to take check x-rays. Orthogram will also helpful in assessing the reduction of the radiocapsular joint. Coming to the type 3, here there is a varus force involved. The proximal ulnar metaphysis, mostly it goes for a green stick fracture and the lateral dislocation of the radial head happens. So how to reduce this? Again, reverse the mechanism. Since there is a varus force, you have to give a valgus force, and to immobilize it, we have to put a extension cast, but many a times you have to fix these lesions. So most of these type 2, 3, 4 as well as these equivalent lesions with proximal radius fractures, they're all difficult to manage conservatively. They will need surgical stabilization. So whenever there is an length unstable fracture in the ulna, or whenever there is a complete fracture, you immobilize it, you fix it with intramedullary or plating. And if there is an intra-articular fracture in the olecranon, you have to fix it. If there is a proximal radius fracture, it might be difficult to reduce it by closed means, then you have to put a K wire and elevate it, or you have to use a Monteggia technique to stabilize it. And if there is a loss of reduction in the follow-up X-rays, then again you have to fix it. So let's take one more example. This is a slightly delayed presentation. This boy sustained fall 3 months back. At the time he was having some pain, so he was treated by some cast elsewhere. So now he presents to us with pain in the right elbow and restricted range of motion. So this is his X-ray. So in this, the glaring thing is the radial head dislocation. But again, whenever you see a radial head dislocation, you have to draw the line in the ulna, the Mubarak's line. As you can see, this has been a plastic deformation which has been missed. So here, as you can see, the maximum ulnar bowing is in the proximal aspect, but it is not more than 3 millimeter. That is this concept. Whenever you see a late presenting case with a maximal ulnar bow more than 3 millimeter, and especially if it is present in the proximal part of the ulna, then you may need to go for more angulation while doing the corrective osteotomy. We'll discuss it a little bit later. Here also you can see there is some ossification proximal to the radial head. This is nothing but the annular ligament which has been slipped and bunched off. It has become calcified. So why should we treat this by a patient? Can we leave him as such? No, because it will result in pain, instability, restricted range of motion, and progressive deformity, a cubitus valgus, which in turn may result in tardy ulnar palsies. The radial head will become deformed. Later on, you may not be able to reduce it. It will result in arthritis or subluxation of the distal radial ulnar joint. So all these problems can happen when you miss to treat the Monteggia fracture. So now, till when you can treat? This paper from Japan, published in 2009 by JBJS, they have showed that if the patient's age is more than 12 years, the results are poor. And if the index injury happened more than 3 years ago, then again the results are poor. Why? Because the normally concave radial head will become deformed and become convex. The capitulum may get flattened. When you try to reduce it, when you even do an annular ligament reconstruction, it will get subluxed post-op, or it might become arthritic and stiff. So now coming to the surgical technique. So which approach we should use, how to approach the ulna first or the radial head first, what to do with the annular ligament, how to fix. We usually use an extensile Cocker approach. So this approach helps you to expose both the ulna as well as the radial head. So the interval is between the unconeus and ECU supplied by the radial nerve and the posterior interosseous nerve. Here you can even decompress the posterior interosseous nerve in the brachialis brachialis interval. Once you expose the radial head, open the joint, you can see the annular ligament which has been slipped and bunched up in the radiocapitular joint. So this slide is from Dr. Peter Waters. He has given this stepwise diagram how to reduce the or how to reposition the annular ligament. Once you identify the annular ligament, you have to isolate the center of the annular ligament, create an opening over there, and to dilate the opening, you may need to apply some radial cuts and also make some sutures so that it will be helpful to pull the annular ligament. Once you have enough opening in the annular ligament, then you can easily pull it along the neck of the radius and then you can suture it back. So this is positioning is not possible always. In that case, you can incise and repair the annular ligament also. So in such early presenting cases, once you do all these things, the radial head has to be cleared of the radiocapitular joint has to be cleared of the fibrous tissue, and also the proximal radioulnar joint has to be cleared of the fibrous tissue. Even after doing all these things, sometimes you may not be able to achieve a good reduction. Then you have to go for the proximal ulnar osteotomy. Why in the proximal ulnar? Because it retensions the interosseous membrane in a better way. Also, it heals in a better way. So the osteotomy is an angulation distraction type of osteotomy. As I have told before, whenever there is a maximal ulnar bow more than 3 mm and it is in the proximal aspect of the ulna, then you may need to go for a more angulation in the osteotomy. Sometimes an angulation is not enough. You may need to go for distraction also, and if the distraction exceeds more than 1 centimeter, then you may have to put a iliac crest graft over there. So once you have finished everything, once you have done an angulation osteotomy and fix the ulna, then check the radial head stability in the radiocapitular joint in varying ranges of motion, not just in the flexion extension, but also in the supination pronation. So you have to always check the stability before closing up. So this is the follow-up of the child is doing well. Dr. Venkatas from Ganga, he has actually published this paper on sliding angulation osteotomy. It's a minimally invasive procedure where he does a step cut osteotomy and slides and distractions and fix it with a single screw. In the early stages, the simple osteotomy will reduce the radial head, but sometimes it may not be so. So you have to go for open reduction of the radial head. Now, before finishing, I will just give a talk on this concept of transarticular radiocapitular wire. Many surgeons, even now, they have this habit of using this so that they can sleep well at night. I don't know. This actually results in sleepless nights because once this wire fractures, it breaks, it is a disaster. You can't remove the wire, you have to dislocate the joint, and it will also result in increased stiffness. So better avoid leaving the transarticular radiocoupler wire in situ, but you can use it during the surgery for temporary templating, as discussed in this paper by Dr. Bay. So, like in DDH, what we do, we reduce the hip joint, then we put a transarticular wire, then we do the osteotomy on the femur. It will help us identify how much amount of shortening we have to do. So, similarly, here also this temporary radiocoupler wire helps to template the ulnar osteotomy. But that's it. You should not leave it inside. So finally, to conclude, don't miss the acute Monteggia. Always, whenever you see an ulnar fracture, check the radial head. Whenever you see a radial head dislocation, you have to draw all the lines, the Mubarak's line, the radiocapital line, and the lateral humeral line. To reduce, you have to reverse the mechanism. Once you reduce the radial head, you have to ensure it stays inside. Always take check X-rays, and if it's not staying inside, you have to stabilize it. If you miss this Monteggia, there will be significant sequelae in the long term. So as discussed, less than 3 years of the from the index injury, and if the child's age is less than 12, there will be better results. And always, along with ulnar osteotomy, open reduction of the radial head may be needed. Rarely we do reconstruction of the annular ligament. Most of the times in the early cases, it's just a repositioning or a repair. And avoid leaving the transarticular radiocapital wire in situ. So I thank you.
So Ashok, that was a great talk. Uh, I mean, all the slides, I find it as if I'm talking, It's a nice presentation.
Thank you, sir.
One thing which I would like to bring to notice that we have many people, they just do the ulnar osteotomy and they try to, they think that the radial head will reduce it in very easily. So for all these fellows, residents, when we do an open reduction for chronic Monteggia, there's a lot of soft tissue, and there's such a nice slide of Dr. Waters that annular ligament is lying in. So in very rare cases, just by doing ulnar osteotomy or lengthening, we get the radial head in. Even in Venkat Das's series, about 30 to 40% radial head got resubluxated, at a longer follow-up after doing the sliding osteotomy. So you can do different types of osteotomy at ulna, but the clearance of radiocapitellar joint is a must that we all should understand. Another thing is there we always have to look for PI and palsy common, and we have to. Am I audible?
There's a little bit break in your voice, sir.
Okay. Okay, so I'll stop talking. And do we have any question? Fine, thank you, Ashok. That was great talk.
Thank you, sir.
And I would invite Kevin, because we see many times older patients, the radial heads which are out are deformed, and so we need to have a better understanding of the problem. And I just met Kevin yesterday, and they have a different and important approach. So Kevin, can I invite you to deliver your talk and show how you address this problem?
Sure. Do you guys see my slides okay?
Yeah.
And hear me okay?
Yes. Yep.
Fantastic. All right. Well, I'd like to thank my fellow John King who put this together for a case that we did a few years ago now. We have good follow-up on. So kind of the case, an 8-year-old female who showed up to ER for a right elbow injury. She was at a bouncy house, did a front flip. I'm not sure if you guys have bouncy houses here, but a little trampoline blow-up thing that kids play with. Did a little front flip, landed on her elbow funny, had some pain. Nothing terrible. They waited 5 days to go to the ER because they thought it would get better. Though otherwise pretty healthy except for a nursemaid's elbow a few years ago. So this is our exam. She had pretty good motion, like block of flexion to 130 degrees, but otherwise full motion. No swelling, but the palpable radial head anteriorly, especially with extension, you could feel it anteriorly. where it was tender. And so here's your X-ray from the day of injury. Very clearly a chronic Monteggia, but you can see the overgrowth as well from the capitellum to where the radial head is. It's fairly overgrown, but there's still a concavity to the radial head. So can you guys see that pretty well?
Yeah.
So forearm X-rays kind of show the same thing. There's definitely a bowing of the ulna, so Mubarak's line that we talked about in the previous um, talk definitely shows that the ulna is also, incorrectly formed. So we went back through our notes, found the X-rays from her previous ER visit in 2015. So that was February 2016, 2015. Her visit was October in 2021. So 6.5 years after her injury, her initial injury. This was the ER visit. Seen, had a nursemaid's reduction performed, and quote unquote stable. And was sent out. They did not recognize the dislocation that happened at that point. Uh, had 6 years of radial head. So what do you do in these chronic cases? Like, what does the literature say, right? So some people would say, I do not recommend surgery in patients with radial overgrowth, while some people will also say you got to fix it when you can, even if they have a small chance of remodeling. So, but what can you do that's a little bit more advanced, right? Now that we have sort of ability to do some more planning, people started doing three-dimensional planning and patient-specific guides and implants to help with these chronic problems, right? You have a bowed ulna, you have a shortened ulna, an overgrown radius. Like, how do you manage all these things at once? But 3D printing can, 3D modeling can help with that. And this paper was sort of an early look at it. What do you do with 3D modeling? But you improve motion, you improve in pain and strength. They also looked at how it worked in the operating room, right? You had shorter operating times when compared to conventional operating cases. More were considered united at that time, but still a couple had revisions for non-union. And then what do we do for the late chronic Monteggia fractures, right? So what do you do for these patients? There's some that were, in this study from 1 to 83 months. So about the same time course as our patient at 83 months. Most of these patients did well, no arthrosis, and a couple of patients still had persistent subluxation dislocation. So their thoughts were within 40 months of injury or before age 6, they had full recovery. Before age 10, they had clinical results were fair to good, but still better than before. A similar study out of Japan looked at these patients, and they thought that kids who had fixed within 3 years of injury or were less than 10 years of age, 12 years of age, 12 years of age, have pretty good elbows without arthritic changes. But after that, you may have troubles. So they still advise to fix them if they were outside that criteria, because all the clinical outcomes were improved after that. So what do we do? Well, we can do it, right? So what we did is a company called Materialize out of Belgium that we've used for our preoperative planning. It's kind of expensive, but we've convinced our hospital that it's worth the added cost by decreasing operating time. So what do we want to do is we want to lengthen the ulna to get the alignment back, redust the radial capitellar joint, and potentially have to fix the radius too. And the first one I did with this, I actually had to do planning for both the radius and the ulna. So what we do is do a 3D CT scan of the operative and the non-operative sides, and we overlay them side by side in a flip manner, so you have a comparison. And you can see here the blue is the normal and the white is the abnormal side. And there's a significant deformity of the ulna, sort of in the proximal third of the shaft of the ulna. And so what they do is they template an osteotomy, and doing a sliding osteotomy is much better than just a straight transverse. By sliding, you can actually lengthen and you maintain cortical contact, so you don't need bone graft, and you can get it to heal quite well in these kids. And they also can template the 3D rotation of the radius around the ulna. Once you've fixed it, how does it rotate? Is it clearing, basically? So what happens with the anterior bowing of the ulna is that it blocks the radius from progressing. And when you pronate more, it actually, when you hit the ulna, it's going to lever the radial capitellar joint out. And so it maintains the dislocation if you don't fix the ulna correctly. But you can template that and model that in 3 dimensions and make sure that it works. And you can actually do it in simulated motion videos. And so what they do is they give you cutting jigs, and the jigs you kind of put on the ulna, and you put some screw holes in the ulna and the radius, and model the cut in the right plane. And then you have these sort of guides you can put on. Those guides you pin into place and you drill through the drill holes. You have to model what kind of plate you want to use, what kind of screws, you're locking, non-locking. You plan all that ahead of time. So you simply have to go in the OR, put these jigs on, make some cuts, make some drill holes, and then make the cut for the bone with this little osteotomy guide. And then you pre-contour the plate. So the plate, they give you the right number of holes. So this was a 10-hole plate, a 10 degrees bend approximately to get around the osteotomy and 20-degree bend distally. And that helps line everything up and it gives you the right distraction at the same time. So you just have to put the plate in. Then what you have to do is do the open approach to the radial head. So when you go in there, you can see, and Mullen talked about this a little bit, that there is an annular ligament and there's actually a separated joint almost where the annular ligament has sort of fused shut. But you have to open that back up again. And we did this a couple times a couple days ago when we did 2 chronic Monteggia fractures. We found the annular ligament, we opened it up, we got it back around the radial neck and reduced the radial head. We can tie the annular ligament back around itself and maintain the alignment and fixation. So this is reducing it. You can see that it's being held. The annular ligament is actually right here. We've repaired it already at the radial neck side, and that's helping to maintain the reduction through this approach. And then I have a video, which is playing weird because it's on a Mac. But the idea is that with full rotation, we're not doing anything. We fixed the ulna, we reduced the radial head, and it's maintaining in stability even with full pronation. And that's what you want to see in the operating room. So you have good stability before you close everything up because the osteotomy is what's key. Fixing the bone is what makes it right. So this is the planned outcome when you're done. And then this was the operative outcome that we had. So if we look in comparison, the operative outcome and the outcome from the template, it actually looks pretty darn similar. And notice that the radiocapitellar joint is lined up perfectly on this as well. So we keep them overnight for compartment checks. In a splint, they come back a cast with them in above elbow casts and return at 6 weeks. So she comes back at 5 weeks. She's maintained alignment. She had some skin irritation from the waterproof cast, but otherwise was okay. And it's healing nicely. And then this was the forearm x-rays at 5 weeks. 7 weeks, we had casted her a little bit longer just to maintain protected immobilization. And then this was at 3 months. She's healing nicely. And this is the final outcome at 3 months, pre and post-op comparison. You can see the bow of the ulna is reduced to a normal look. There's still some prominence of the hardware, which we knew was going to happen. And the radiocapitellar joint is lined up. So 1 year post-op, similar outcome, fully healed osteotomy, maintain ulnar alignment, and the radiocapitellar joint is normal with full rotation, full flexion extension. And you can see from the Park-Harris line distally here that she's growing normally at the radius, despite the insult of surgery. Then did harbor removal because it's prominent, and the bone looks perfect. 2 months post-operatively. She's back to full normal self and haven't seen her since. So from that perspective, we can see that there's a lot of options, sort of advancement options to really guide your treatment, make it faster, make it better, make it more predictable, and line it up. So I've done that in a few cases. It's not always perfect, so you have to not always trust the computer. The first case I did the osteotomy, fixed everything, and it was still dislocating in full pronation. And so I bent the plate a little bit more and over exaggerated some more, and then it was stable. So you can't always trust the computer. You have to use your clinical operative findings to really guide your treatments. But the same idea, the sliding osteotomy, the oblique osteotomy ulna is the best way to do this. You can do it for even acute fracture, just slide it. You can bend it. It will still maintain cortical contact. No need for bone graft. Heals really nicely. There's a question, do you never need radial shortening? You can. I think the question is how much lengthening can you get? You know, the radiocapitellar joint, right? If the radius is dislocated, it has no opposed growth force, and so it's going to grow longer, but until it hits the the distal humerus, and then it's going to stop again. So you can't ever grow more than about a centimeter of most of overgrowth, and you can lengthen a centimeter very easily. So you don't have to shorten the radius, but you
However,
have to lengthen the forearm in some way, either
um,
lengthen the ulna or shorten the
yeah,
radius. But doing the sliding osteotomy is sufficient.
So what I feel important is to see the radial notch of ulna. Many a times because of the primary fracture, it is shallow, and even though the radial head is concave from the top, it remains sublux. Or
Mm-hmm.
even intraoperatively, we find it good, but postoperative there is mild subluxation. So if there is mild
Yeah.
subluxation, then I just leave it. I don't, go back, because it aligns
Mm-hmm.
the forearm, and the instability is taken care of. So that's a great way to deal
Yeah.
with this, and that's nice talk. We have been doing using this for different proximal femoral osteotomies, and 3D printing is quite possible here with the jigs. So it's important to take this concept in the practice, right? So we'll have, if we have question, I'll ask you later if the fellows have some pertinent question later. We have three interesting cases, Kevin, and I would like Bipin to share his screen. Now, before many years, we didn't have access to 3D printing, and then we'll show how we tackle some technical problems we faced intraoperatively. And the literature suggests that you should not attempt reduction after 3 years. But in India, we face a lot of neglected patients coming, and there's an older child and presented after 8 years of initial dislocation. And Bipin, kindly share your screen and start.
Yes, sir. Good morning, everyone. Today I am presenting the 14-year-old boy with a late neglected Monteggia lesion. A 14-year-old boy who sustained an injury along forearm before 8 years, who had a restricted elbow flexion, anterior bump, progressive cubitus valgus deformity, and occasional pain with no distal neurovascular deficit. On the radiographs, we can clearly see the terminal restriction of terminal flexion and anterior bump. So here are the radiographs suggesting missed Monteggia, the anterior dislocation of the radial head. The radial neck shaft angle difference was 9 degree, and the carrying angle difference was more than 20 degree.
So, Vipin, please stop. Kevin, we can see the top of the radial head, it looks little bit convex and not absolute concave. And this is an 8 years old injury. Now he presented with a complaint of pain whenever he lifts some heavy object, and he came categorically that his deformity of cubitus valgus is progressing. So how would you approach such late presenting and older children?
Well, to answer the first question, yeah, there's some, probably decreased concavity of the radial head, but it still looks somewhat concave.
Yeah.
It's a cartilaginous structure more than a bony structure, so sometimes I'll get an MRI to see if the radial head is truly concave. In my talk, you could see the radial head after 6.5 years still had concavity, though it was thickened, like the rim was thickened because it hadn't been having that pressure, but still had sufficient concavity to maintain alignment. And so, in this patient who's nearly done growing, the olecranon is sort of at the last stages of closure. There's still some, mild remodeling potential with fractures and osteotomies, but not necessarily at the joint. But I still think there's some cortical contact there that can help remodel the radial head. So I would, discuss the osteotomy technique, right? You can do an ulnar osteotomy. There's clearly a deformity of the ulna that you have to correct, and there's shortening, relative overgrowth of the radius. So you have to lengthen through the osteotomy, and then open reduce it, find the annular ligament and repair it, and then go from there. So
Yeah.
that's what I would offer the child, though there's, risks to all surgeries and benefits. So that's what we talk about, family-centered care, is discussing risks and benefits and seeing what they want to do. Because it's not, horrible, but you certainly have probably worsening progressive valgus of the elbow without that radial head to hold the elbow in place, and then eventually arthritis in there, somewhere down the road.
Exactly. And then we learned and read about the radial neck shaft angle. If some of them have suggested if this radial neck shaft angle is more than 10 degrees, then even after you align it, there might be some subluxation. And I think there this 3D printing comes in play there, because you can print the radius also, and then you can forecast that how much of ulnar angulation can be done. So with all this discussion with the family, that he might end up with some stiffness, he might end up with some restriction of rotation, we went ahead with the intervention. Yeah, Vipin?
Yes, sir. So here is the paper in JP 2002 suggesting the degree of preoperative angle asymmetry associated with the flexion contracture. And another study published in JBGS 2009 that suggests if open reduction for the treatment of missed Monteggia fracture is performed when the patient is less than 12 years of age or within the 3 years after the injury, good long-term clinical and radiological outcomes can be expected. So we did the intervention. Open reduction of radial head was done, clearing of radiocapitular and radioulnar proximal radioulnar joint. The annular ligament could not be identified. We did the ulnar flexion distraction osteotomy, but radial head did not move.
Yeah, so at this point, Kevin, I did everything. Open reduction, clear the radiocapitular joint. Didn't find annular ligament remnant. They're atrophied, or I could not find a structural annular ligament. And then went on doing ulnar flexion distraction osteotomy, thinking that once we do the osteotomy, radial head would start moving, but it was quite tight. It was not coming down. And so, yeah, Vipin, show what we did next.
Yes, sir. So we did the radial shortening, derotation, and temporary transfixation of joint with ulnar fixation with plate and radial nailing.
Yeah. So we ended up doing radial shortening, and that radial graft was used in the ulnar distraction, and then radial head came down. I at that point still that was not very stable, and so I resorted to putting a transcapitular wire temporarily. Yeah, and
KY was removed after 3 weeks. So this is a 3 years follow-up, suggesting the correcting the coronal alignment, Ubetus valgus, and gaining the full range of motion. Thank you.
fortunately,
Looks like he lost a little supination, but otherwise did really well.
Yeah. So he had some restricted terminal supination, and there's still valgus alignment. Now it has maintained over 3 years. So this case to just brought a point that if nothing works, then radial shortening is one of the options, as we do in DDH. You do it, hold it with a clamp, and then you can pull it down, put a trans radiocapitular wire temporarily, fix radius, fix the ulna, and if then you remove the wire and see if it is stable, then you don't need. If not, then you keep it for a few weeks, and we'll show now we have avoided radiocapitular wires, and we'll show some other method.
Yeah, I think, when you think about this, a stepwise approach, right? You start with the radial head cap, reduction, you do an ulnar osteotomy, and then you see if you can get it, what else you need to do. And then eventually you can get to radial shortening if you need it. They're really tight ones. I think you could have maybe distracted the ulna more, but with a transverse osteotomy, it's difficult. Like the sliding osteotomy, you can actually use a clamp to help distract, which is what we did a couple of days ago. That really helped us to get the length back. It helped.
So I use a lamina spreader, at the ulna, try to distract, but somehow the radial head was very stiff. But now next time I'll try this sliding osteotomy. So it's another interesting case, mainly for residents and fellows. Yeah, Weber, please go ahead. Yes, Bipin, who is presenting this?
You're muted right now, Pipu.
Weber, you are muted probably. Uh-uh.
God.
Sir, is it visible now?
No, we lost the PowerPoint.
Yeah. So
There it is.
Is it
Yeah.
visible now?
yeah, Weber.
Yeah, so this is an X-ray of a 4-year-old male presented with injury with fall on outside hand. So this X-ray was done elsewhere. The primary treatment was given elsewhere. So
So let's inquire that any fellow, the resident, what do you see here? Kevin, do you have your resident with you or your fellow?
Yeah, fellow.
You want to come in?
Jules is here.
Yeah, so you have an AP and a lateral of a skeletally immature individual demonstrating what appears to be a buccal fracture of the proximal ulna. You have anterior subluxation of the radial head at the radiocapitellar joint. The AP alignment looks pretty anatomic, but you can see the buccal on the lateral, especially on the posterior cortex or the dorsal cortex of the ulna. So I guess it's kind of like a beta 1.
Right. So that's a very good observation on day one. But most of us, most of the orthopedic colleagues or the general orthopedicians, they would miss the Monteggia because the radial head is not ossified. And so we should have a habit of drawing lines, as Kevin has already made a line here. So to make sure that this center of radial axis is passing through the capitulum. Yeah, Weber, move ahead and show what happened.
So first I would like to ask, how will you manage this now?
Yeah. So can you what would be the ideal treatment, Kevin, for this kind of injuries?
Well, I would try a closed reduction under general anesthesia and see. If you can get the ulnar aligned, the radial head isn't completely out, so it'd probably be better, right? You'd sometimes have to supinate and then flex it down. If that doesn't work, pronate and flex it down, and then see if you can get the radiocapitellar joint aligned. If you're having trouble seeing, an arthrogram is a great way to do this under anesthesia without, any
Right.
added risk really. And then if you're having trouble keeping it there, or a K-wiring of the radiocapitellar joint temporarily to allow that proximal ulna to.
Right. So you
Feel will
would
be
put
good.
K-wire in all the cases, or would you make intraoperative decision about it?
Most of the time in the acute setting, you can reduce it and hold it without a K-wire.
What's the degree of immobilization? I think that the first Ashok talked about hyperflexion plaster, but that is a bit risky. How would you immobilize them?
I would typically put it in about 70 or 80 degrees of flexion, and come back in a week, and then you can flex it up a bit more if you need to. So,
Yeah,
but
that's
it hurts to flex it up more, but you definitely want to watch out for the swelling.
a great idea. Yes, Weber.
So the primary treatment given was plaster in situ, and this was the 1-1 follow-up X-ray. The radial head was still subluxated, and this patient presented somewhere else. Now, are you happy with this reduction?
Yeah. So the primary surgeon missed the radial alignment, and they gave just plaster in situ. In a month's time, the olecranon fracture healed very well. But as we can see now that the radial line is not aligned with the capitulum. So we are not very happy with the reduction, right? And now the patient goes to another surgeon. Yeah.
So could you consider
So after 2.5 months,
whatever.
He presented with progressive subluxation of the radial head. And then he was treated elsewhere. Oh, wait. Where's the X-ray?
Just one point about
Yeah.
the radiocapitellar line is that
Hmm.
based on our MRI study, the capitellum is not ossifying in
Center.
the center of the cartilaginous. It's actually anterior. So it's not always pointing to the center of the ossific nucleus until about age 7 to 8 on the lateral view and about 9 to 10 on the AP view. So you got to be careful measuring it. It should never be anterior to the ossific nucleus, but it can be posterior in a normal setting when the ossific nucleus is small. But in general, it's going to point to the center of the cartilaginous capitellum, but not the ossific capitellum.
Yeah, so that's very important because some of our fellows they come that there seems to be a posterior subluxation of radial head, but that radius is not posterior, but it might be aligning. But if this is anterior, then it's a short subluxation. Yeah, Weber, you can go further.
Yeah, so this fracture was described by Dr. A.C. Hume from England, who described a radial head subluxation with undisplaced olecranon fracture or minimally displaced olecranon fracture. And the mechanism of injury he proposed was hyperextension of elbow with pronation of forearm. So this again presented to elsewhere, and they did an X-ray by reducing the radial head under the X-ray. And since the radial head was reducible, they close reduced it and gave the patient a brace.
So again, like so this was a second colleague involved. We have a lot of adult orthopedic colleagues. So they saw that radial head is going down, but again, you can see that line is still not completely aligning, but they misinterpreted this as a reduced radial head. And then they gave a elbow flexion brace, thinking that it will stay there. But we all know that this will jump out, eventually. And that's what happened. Yeah, Weber?
So this was an X-ray of 3.5 months. Now the radial head is subluxated anteriorly. And now, how will you plan this patient?
Yeah. So we'll go as the same manner, in a stepwise approach.
Yeah. So what we did, we took an lateral extensile Cocker approach, and we usually routinely dissect the PIN in all the cases between brachioradialis and brachialis. After that, we locate the rent in the we locate the rent in the annular ligament. We dilate it, we deliver the head and reduce it. And after reducing the head, we check for the stability. If the patient needs an ulnar flexion osteotomy simultaneously, we expose the ulna shaft from same incision, and we do a flexion distraction osteotomy of the ulna. So this was
So this
done.
was actually
These were the
Weber,
intra-op images.
can you go to that video?
And this was 6 months. Yeah.
Yeah, can go back and can you show this? See, annular ligament is, Kevin, I have found it even after many cases, many it is difficult to identify the annular ligament. But in this video, I have shown how to enlarge. Weber, can you bring that point, how annular ligament opening was enlarged? So I always advise fellow to go proximal than the radial head. Annular ligament lies proximally. And then, yeah, so this is a bunch of annular ligament, and with a dura, I found the hole in it at the top, anterior to the capitellum. And then you try to widen it. And if it is not, as Dr. Waters' slide, Dr. Ashok mentioned, you make some radial cuts and then bring it down. Yeah, like that. And then the radial head will sit in. So this technical point is very important. If you are not able to bring the annular ligament well, there are high likelihood it will get re-subluxated on follow-up. But Kevin, I learned that
Yeah,
you
it
do
almost
it
makes
with
a separate
two
joint.
incisions. Yeah, yeah, yeah.
Yeah, I
I'm
kind of make almost like an oblique cut and then do it, but I try
yeah.
to dilate it first and see. But it makes like a separate joint anterior, and the annular ligament is proximal, like you said. You have to put it back over the neck, and then either like if you can push it through, it'll stay, or like make a little radial cut and then suture it with some non-absorbable suture. It will then hold around the radial neck and keep it in place better. But you sometimes have to clear out that sort of tissue in the posterior lateral radiocapitellar joint to get it to stay, because that tissue can block the reduction a little bit as well. So
I was in Boston in my early practice, and then I saw Dr. Waters doing decompression of PIN in BR interval. And since then I've started, I kept on doing it, and many people ask why it is needed. And I asked Dr. Waters also why we need this, because we never see this PIN policy post reduction. And he told me you need one instance to change your practice, and you will need only 5 minutes to dissect and keep this nerve free. So hence I've continued doing that. It's not a must, but if you do it, the rare, very stiff cases, you may avoid this post-operative PI pulse. Yeah, Weber, can you show the final outcome? Yeah.
These are the final post-op X-rays, and we did the implant removal. The osteotomy healed well. The radial head was stable, and the patient had good range of motion with no complaints.
Yeah.
So the message is, when you see a proximal ulnar fracture, don't forget to see the radial head. Do not miss a Hume's fracture.
Fine. Yeah. Thanks, Weber. That was a nice presentation. We'll go with the last few slides, last talk. A bit of technical variation. We have been doing offlet for unstable Monteggia after all the exercise. Shashank, you want to share your slide? So all the fellows are sitting in one room. That's why probably internet is divided.
$5G internet here.
Can you see this screen, sir?
No, we don't see this. So
Yeah.
and we have the echo of voice. So I think you people are sitting fairly together. So just stop one of the device.
Is the screen showing now?
Yeah. Shashank, please reshare your screen.
No good deed goes unpunished. Never exercise.
Okay, now we can see your screen. Yeah.
So I'm going to talk about a novel method to stabilize the unstable radial head in the chronic Monteggia
Buy
surgery.
2 get 1 free. Duty free.
The standard surgical principle in any chronic Monteggia fracture surgery would be an open reduction, then doing a proximal ulnar osteotomy and checking for the stability, and then doing the annular ligament reconstruction. The main problem here is after osteotomy as well as annular ligament reconstruction, there is a still possibility of the redislocation of the radial head in a pronation or supination movement, and it can be unstable intraoperatively, and there might be shift with the forearm rotation. The annular ligament reconstruction usually gives stability only in the sagittal plane, but not in the transverse plane. So the main algorithm which we followed was, in a chronic Monteggia fracture, we did an open reduction and then we did an ulnar osteotomy and checked for the stability of the reduction. If yes, then the cast. Otherwise, then we would do an annular ligament reconstruction. And then if it is unstable in spite of doing this, then there would be we would do radio-ulnar K-wire. So the different types of the temporary fixation for the stability of the radial head would be a transcapitular K-wire as well as a radio-ulnar K-wire. So the concept basically behind radio-ulnar K-wire is it protects the reduction and it gives a temporary stabilization to the proximal radio-ulnar joint, and it also allows healing faster. So the indications include persistent instability after osteotomy, or there's a redislocation in a pronosupination movement, or there's a doubtful intraoperative stability. Why not transcapitular wire and why going for a radio-ulnar? Transcapitular wire is usually an articular joint. It goes through the joint, and there's a risk of cartilage damage, and there is a risk of stiffness in the pronation and supination movements. Whereas radio-ulnar K-wire is an extra-articular, and it is safer, and it it gives a proper temporary stabilization. Study by L.C. Langenberg et al. Has described that has described about the complications of this transcapitular K-wire and their preference of using the radio-ulnar K-wire instead of transcapitular K-wire in their study. The following complications were which they mentioned. There was a pin. There would be a higher risk of pin migration or a pin breakage, as already explained by Sir. And there is a chances of breakage, and that will lead to a difficult surgery to remove the pin, and heterotrophic ossifications, which will lead to restriction of the pronation and supination movements. And there's also a chance of the infection of the tract, pin tract also. So this is a study in our clinic which came in a 6-year-old child who came with a chronic Monteggia. This was the pre-op X-ray, clearly showing the dislocation and the fracture of the dislocation of the radial head. And we did open reduction along with the radio-ulnar K-wire, and this is the immediate post-op X-ray. So after 4 weeks, the radio-ulnar K-wire was removed, and the post-op X-ray is showing a well-reduced radial head. Thank you.
So this, unfortunately, we didn't find the intraop images, but this happens very rarely, you know. Okay. So this happens very rarely that after doing this chronic Monteggia, all these things, you still find it unstable, especially on flexion extension, it remains in, but with pronation, it goes off. Pronation, it goes. In that case, you can pass a trans-ulno-radial K-wire, which comes out of the radial neck, mildly prominent, and then you cut the wire flush to the ulnar shaft, a bit prominent, so that you can remove it at later date. Shashank, you can stop sharing your screen. Yeah. So that's another way for few unstable of late. We have started in not a transcapitular but a radial. However, that is needed in very few cases, not in all. Most of us, they get well with a well-planned ulnar osteotomy and annular ligament treatment. And we even do not require, I have not done many annular ligament reconstructions. In your case, Kevin, there was narrowing of the neck, right? Of the radial neck, and some white changes or the avascular kind of change in the radial head, which improves with the time, that I also observed. Yeah. So I think we have overshooted time for 4 minutes. Thank you, Kevin, for your valuable time. And thanks, everyone.
Thank you for inviting me.
Yeah. Have a good day and have a nice time. You're operating in civil hospital today?
Yeah, and then I'm going back to Health and Care Foundation Hospital. So we have cases both places today.
Oh, great. Best of luck. Have a good day.
Thank
And
you.
thanks,
Take care.
Ashok. Nice presentation. Thank you very
Thank you,
much.
sir.
Yeah, we'll meet next week for some other topic. Thank you.
Sure, sir. Bye.